Hello, how's everyone doing today? Thank you for joining in, and thank you to Mohammed and Sherry and for the invite and allowing me to participate in this discussion with you today. Excited. It's a nice day outside, so we'll try to keep this brief and relevant as possible and get you guys going through the rest of the conference. I see there's folks hopping in. So I'm going to be discussing today some inclusion, exclusions, and special considerations for ECLS support. So we'll get going. I have no disclosures I have nothing to disclose, anything related to this presentation. The objectives for today is we're going to discuss and hopefully by the end understand the inclusion criteria, exclusion criteria for ECLS, and then we'll discuss some special considerations too as well. So ECLS, and I took this from our ELSA, from the ELSA website for anyone who accesses that, just so to keep it is just so I'm not making a definition, but ECLS is the treatment of using man-made heart-lung machine to support the body when the organs are too sick. And, you know, that can be a combination of several devices here. MCS is kind of the overall term. So is ECLS, RVAD, ECOR, and whatnot. ECMO, of course, is what we tend to refer to. ECLS and ECMO tend to be interchangeable, which, as we know, the ECMO is capable of supporting both heart and or lungs for days and up to weeks. One thing that I always point out to, especially when I'm speaking with family, is this ECMO is not the cure-all solution, but rather it provides us a limited amount of time, just because you never know when that time may be to reach a solution or an outcome for the patient. And then ECMO, of course, because of the oxygenation portion, does use a blender for the delivery of oxygen and CO2 removal. So there are different types of ECLS. We have veno-venous, veno-arterial, veno-pulmonary. I kind of threw that in separate because that can function as both ECMO and ECLS as an RVAD device or as an RVAD with an oxygenator. And then we got some complex configurations, hybrid configurations too as well. So for those that really enjoy this kind of stuff, complex hybrid types of support here, I just kind of threw this in. I'm not going to go over every single one of them, but I just really enjoy the complexity of it and how sometimes you have to get really creative when you're supporting these patients. So I'm going to start off with a case study here. First one we have here, and this is on day one, we have a 66-year-old male. And as you can see there by their past medical histories, they have a significant cardiac history. Past medical history, as you can tell, diabetic, kidney disease, stage 4, interstitial lung disease, and this patient's already on HOMO 2. They also have a significant past surgical history. And all this, hopefully once we get to the end, it'll make sense as to why it's important to know all this. But they've had bypass, both CAB and femoral artery bypass, TAVRs, and AAA stents too as well. So the patient comes into the ED with a completeness of shortness of breath and lightheadedness. And as soon as we get vital signs, report of vital signs, patients have been in rated 156, AFib with RVR. So they are, I guess you could say, hypotensive, but also when you're working with somebody who has an EF of 20% and ischemic cardiomyopathy, I mean, the blood pressure may appear low, but it may be somewhat normal for them. Nonetheless, we would say that's symptomatic AFib RVR. SpO2 of 84, but this is a patient with interstitial lung disease. They're a little on the cool side, and of course they're tachypnic too as well. And as they're sitting in the ED, they've come in responsive. Pulse is questionable to the nurse, so CPR is initiated. Usually this is not long after CPR is initiated. Our ECMO team, our ECLS, we get a consult. And the sequence of events, we kind of get straightforward to it. Is they report to us as the patient's in AFib RVR, went into PEA, got cardioversion, now they're in VTAC, VFib, as you can imagine. And then they have an end-tidal CO2 of 8. So just a couple of sequence of events. So whenever we get called for a patient for ECMO, a couple of things that we always like to, as a team, evaluate is what's the underlying pathology or cause for arrest? You know, what sort of support will be needed for the patient? If placed on ECMO, what is going to be your exit strategy? These are questions that I know we're going over it one by one here in a discussion, but we actually in real time, you go through these questions fairly quickly and address them quickly. And of course, you always want to consider, you always want to evaluate for any exclusion criteria. So as we discuss here, our inclusion criteria, and this is kind of overall for ECLS, is age, 1875. I think this is kind of age across the board. Patient who is going to be able to bridge to a durable device or heart or lung transplant. Patient who's coming out following a transplant and they're having some primary graft dysfunction. In hospital cardiac arrest, such as the patient we just reviewed, or respiratory arrest with a high quality CPR for less than 30 minutes. So this is some inclusion criteria for overall. Other inclusion criteria to go along with that is you have a patient who already may be in house, or you have somebody that have already started, some vasopressors, some inotropes 2 or less, in combination with low urine output, low SpO2 of less than 60. And then if they're prudent in checking labs, their lactate is climbing. So as you can tell, they're in some form of shock and probably more than likely some cardiogenic shock that's going on there. It's kind of a picture. I do work in the CVICU, so we do have a lot of mechanical circulatory support devices. So some of these patients may be insufficiently supported from the cath lab, or they just arrive from another facility. They may have a balloon pump, they may have an Impella, whether it be an RP Impella or a LV Impella for left-sided support, or they may have a tandem heart. All common patients that we would consider for ECLS. Again, going on, a patient who may be intubated. This is some of their ventilator settings that we look at. And of course, these are kind of some settings that we really take into consideration when to put the patient, consider them, evaluate them for ECMO. You have a rate greater than 30, inspiratory pressure greater than 30. FI2 80, and I say 80 as opposed to 100, because once we get to these sort of settings, you can anticipate going up to 100 within a matter of hours, and not wait till get to 100, but rather give us a call early. Ventilator settings is, of course, when we're looking at plateau pressures 30, PF ratio or less than 100, with a PEEP of 10 or higher. And then if you're looking at ABGs, a pH of 7.15 or CO2 greater than 70. So as I'm going to go on, I'm just going to sprinkle some case studies here and there. And like I said, hopefully this all tying together. So this is another case study I'm going to go over. It's a 19-year-old male, gunshot chest to the wound, day 1, no past medical history. Patient comes in, has an emergent lower lobectomy with a left subclavian ligation and a primary repair of the left axillary artery. So a lot of work that went on in this patient's chest. And as you could imagine, 2 MTP trays, massive transfusion trays that were initiated, EBL of 2.5 liters. He's 19-year-old, so he's compensating fairly well with a heart rate of 135. He is tachycardic, which does raise some flags. Blood pressure 92/56, CBP 16, temp is normothermic. Is requiring some blood pressure support, so he's on levo 1.2 mics, and this is at mics per kilo per minute. He's also on a dose of vaso epi, and for protective reasons, while they're ventilating him, they do have this patient paralyzed and on Versed fentanyl. PF ratio is 76, respiratory rate is 30, tidal volumes 275, and they're already on 100% of FiO2 with a PEEP of 15. Here's his ABG, and as you can tell, it looks poor, both from an oxygenation standpoint and CO2 clearance, and the patient is acidotic. So this was an outside hospital consult that we got for ECMO. And again, we get that call, and as we're getting the call in, we're going to start to explore what the underlying cause is. And of course, I'll just start to answer questions as we go along here. So trauma is a origin of injury. There is some hypovolemic shock going on. So we're start to discuss what types of support is going to need it. We can imagine, there's probably some trauma associated ARDS going on here. And for someone who's not in this acute phase, the exit strategy we expect to be recovery. Exclusion criteria, so we'll continue to go on with that. So exclusion criteria for ECLS. So again, this is just kind of across the board for ECLS. Anybody who's Hospice, palliative, or DNAR, then of course wouldn't be. That's kind of self-explanatory. Over the age of 75, somebody who's had a severe neurological injury, unwitnessed cardiac arrest or CPR that's been going on for greater than 60 minutes. Somebody who has metastatic cancer with a predicted survival rate of less than a year. For going to go more specific into exclusion criteria for VA ECMO. So you have somebody who has an unrepaired abdominal aortic aneurysm, or they have a dissection going on that was found as they were brought into the ED. Unrepaired severe aortic or mitral regurgitation with poor LV function. Severe chronic pulmonary hypertension with RV failure. This patient could also be in the late stage of cardiogenic shock or SCI-E. That, this again, the kind of what we recommend that. And this is going to be in combination with a lactate greater than 15. Patients already developed a severe liver dysfunction as evidenced by the AST and ALT numbers here. And then of course, they're in advanced microcirculatory failure with modeling and established purpura going on. So these patients probably not your poster child for ECMO, will not produce a good outcome, or don't want to establish false hope into family with offering ECMO. So for VV exclusion criteria, what we have is anybody who's an end-stage lung disease that is not a transplant candidate, somebody who's in respiratory failure with advanced septic shock involving 2 or more of the following, which is a lactate greater than 10, LEVO of 1.5, severe myocardial depression, and of course, again, advanced microcirculatory failure with severe modeling and established purpura. So again, this is exclusion criteria for VV ECMO. So one could ask, well, what about VA? Again, if you go to consider VA, for this type of patient, the idea would be that you have an exit strategy in place for them, and that would be for evaluation for by the team. Going further, this is going to be the third case study that I'm going to sprinkle in here. So we have a 54-year-old male with non-ischemic cardiomyopathy with an LVEF of 20%, and this is of course on their day 1. So this patient's coming in, they're established. They're on home Primacor at 0.45 mics. Patient is currently being worked up, so he's coming in for a left heart cath and right heart cath. They place a swan, they get the numbers that they need, and the plan is for them to have a colonoscopy in the first day morning. That's kind of the final box they have to check. So the patient's admitted to the CCU overnight, and the patient has an RRT for refractory VTAC with successful defibrillation by their AICD, and they do have, of course, a permanent pacemaker. Patient still maintaining spontaneous airway, alert, completely with it, starting lidocaine drip. And so for the purposes, we do get a call, just kind of lay eyes on the patient, be aware of it just in case. We decide to go ahead and relocate the patient to our CV ICU, which is right next to our ECMO ICU for closer monitoring. And so again, we'll ask the same questions. What is the underlying cause of this patient? And so we know this patient has advanced heart failure. So what type of support would be needed? As this is a discussion that's going on. Well, we would put the patient on VA ECMO. What's going to be the exit strategy for this patient? We're going to bridge them to a transplant. That's going to be the end goal. And any exclusion criteria? Well, really the only question mark is because the colonoscopy is pending, that hasn't been checked off. We don't know. We're not expecting anything positive to be there, but nonetheless, it's part of the criteria to be listed for a transplant. So now we'll talk about some special considerations here. And so first and foremost, prior to initiating, is identifying an exit strategy. I think that's very important when putting a patient on ECMO. How are we going to recover them, completely liberate them from support? Are we going to be able to bridge this patient to a heart and or lung transplant, or can we bridge this patient to a mechanical structures device such as a durable or an LT LVAD or a total artificial heart? That's something that we offer at our institution. Other thing too about the institution is the institution capability. What sort of infrastructure do they have for ECMO? This could be a rural facility that is able to maybe initiate ECMO because they do bypass, they have a heart cath lab, so they do bypass, but they're not able to manage the patient, or are they a transplant facility? So is this somebody that needs to be transferred out to a facility that is able to manage these patients? And then, of course, I think the other thing is multidisciplinary providers. It's going to take a whole team effort from all body organs, disciplines, dietary, PT, RT, and all that good stuff. So it's the capability of that. So one thing, if you do find yourself in a rural area and are going to be offering such support, is having ECLS collaborative agreements with other institutions that can offer all this, and then establishing reciprocals. That's kind of the practice that we have with other facilities around us in our area. Other thing to consider too for these patients for ECMO is knowing their past history. Do they have a heparin allergy? Heparin is kind of the main go at our facility that we use for initiating ECMO and for maintaining a patient on ECMO. And knowing, if there is a heparin allergy, then what options do you have, such as argatroban and Angiomax. And if that is not an option, which we have ran across, is being able to provide plasmapheresis for these patients. And should they have some sort of allergy to heparin, or you're going to bridge them to one of the recovery devices. So again, special considerations for VV ECMO is preserve. Let's ensure that we have a preserved or normal RV function. As we know, for VV ECMO, you have to have that RV function to be able to move blood forward through the circulatory system and back out. So a patient with biventricular failure probably has a pulmonary embolism, a saddle, or completely obstructive embolism of course, is not going to be a good VV candidate. Thing to consider is, again, as I've been going over some of the cases that we've gotten to this point, is knowing the past medical history. Is this patient on HOMO 2? Staging of interstitial lung disease? Is it idiopathic in nature? Or is this a patient who's had a previous ECMO run? So these are things that you definitely want to consider before putting your patient on ECMO or revisiting the idea of recannulating the patient, and then will you be able to exit from that strategy too as well. Other thing to take in consideration, is this an acute versus chronic, or acute on chronic respiratory failure? So a couple of things that we look at is, the intubation timeline. How long has the patient been intubated for? Or is ECOR a possible option too as well, which is the ECMO light, I guess you could say, to help support the patient to recovery. So for VA ECMO, a couple of things that we would consider is, when you're looking at the patient, is shock. And I didn't come up with this term. This is from one of the shock symposiums that I went to, is that not all shocks are created equal. And I really liked it, so I just kind of adopted it. So, learning to identify what sort of shock you're in. Cardiogenic, is it normotensive shock versus late? Are they septic, vasoplegic, sort of like distributed shock? Really understanding why you're putting the patient on VA ECMO. We really tend to evaluate the patients that are in stage renal disease, more scrutinized, I guess you could say. These patients are on dialysis, probably had ASRD for years. They tend to have poor vasculature. We've, tend to be, because they have poor vasculature, tend to be a little bit more difficult to cannulate should you find yourself in that situation. Patients with end-stage liver disease or liver transplant patients for VA, not so much. For VV, we will consider to support the patients, but for VA, it's been a difficult patient to recover in our experience. And then you have the patient with congenital diseases. Some of these patients with congenital diseases could have functional shunts, transposition of the greater vessels, or a patient who has a dual lumen IVC, which is quite interesting when you can think you're on VA, but you're actually on VV. Or a patient with a tortuous aorta. All they can really determine as to what type of support you're on, what type of support you need. Or is this, we've received a patient from an outside hospital, they put on VA following VSD closure, come to find out, our congenital heart specialist said, you need to reverse the shunt because it's a functional shunt. And then the patient came off ECMO in the next 24 hours, which is something to learn, something new that we learned. So something to really consider about these patients when you take a look at them. So going back and revisiting our first patient, the 66-year-old male. So as we go to evaluate the patient, they have a complex, a couple of things that we came to agreement is they have a complex medical history. Most likely going to be a difficult cannulation due to poor vasculature. And if you recall their past surgeries, that they had the TAVR, the AAA, and the FEMPOP bypass. During CPR, as you can notice, high quality CPR for any ECMO patient, that any VA ECMO consideration, end-tidal CO2 of 8 is the poor indicator of is an indicator of poor circulation despite the optimal CPR. So there's a lot more going on here. And then of course we think to ourselves, once we put this patient on, what's going to be our exit strategy? It's going to be difficult to wean, not going to be a heart transplant candidate nor a lung transplant candidate, just due to the multi-organ failure that's going on here already. So in declining a patient for ECMO support, decisions always made between two physicians. That could be the ICU intensivist or CT surgeon, a cardiologist, or whoever may be on the team and that is involved with the patient at that time. So in discussing our 19-year-old, you know, we tend to have a soft spot in our hearts for really young patients. So 19-year-old male gunshot wound to the chest, pretty much can stop at 19-year-old and we're going to say almost yes, almost 99% of the time. So patient was picked up at an outside facility. Our team was activated and deployed. Decision at this time, though, was made to place the patient on BV ECMO and transport back. And the decision is at that point was, well, the patient has no overwhelming or overall healthy history due to no PMH. And then, of course, we know at this point, a lot of this is most likely hypoxia, hypercapnic driven. So the patient's in acute ARD is due to trolley. Exit strategy is going to be to bridge the recovery. And as you can tell by day 3, we were able to already, once we've normalized all the blood work, got him nice and tuned up on ECMO, able to wing off some of the, actually the majority of the vasoactive drips, with the exception of the epi. We did leave that as we tend to use epi as for RV support, just at a low dose, and then aggressively diurese the patient. As you may recall, the CVP on the initial exam was over 16, and that was, you know, just from the shock of all the blood transfusions that he's gotten, fluctuation, and the chest work that he's had done. By days 4 to 7, as we were aggressively diuresing the patient, chest X-ray was slowly clearing up. Patient was able to wing off ECMO. By day 8, we actually extubated the patient and took out all 2 of his chest tubes from his left side, and we were able to comfortably send the patient back to the facility. That's where the reciprocal agreement comes into play. So here is our 54-year-old female with a non-ischemic cardiomyopathy, LVF 20%. So just like I said, this is a known patient, established patient at our facility. So upon relocating the patient to the CVICU, patient goes into a sustained VTAC, this time without successful defibrillation by the AICD or defibrillator. So at this point, the patient goes into an ECPR wing. And so as discussed by the team, we already knew we would put the patient on VA ECMO. And so it's day 2 because it's after midnight. So we did place the patient on VA ECMO. And of course, we knew our exit strategy would be a bridge to transplant. So the patient was left intubated overnight so that GI may come in and complete their colonoscopy, which all that was cleared. As soon as that was cleared by GI, the team committee signed up on the patient to be listed as a heart transplant. Patient was actually extubated later on that day. Day 3, they received an offer, was transplanted, and separated from ECMO intraoperatively without any complications. Patient did really well, and by day 8 was actually discharged home. And so all this is just a result of good planning and good understanding of the patient and having a really good history of the patient. So a couple key things that I like to share is timing is of the essence. Early identification, early initiation of ECLS is what I'm an advocate of. Should the patient appropriately need it, you tend to have better outcomes. Again, I understand that ECMO doesn't come without its possible complications too as well. But if you can sustain it, support a patient on ECMO or ECLS, the earlier the better. It can be too late. So we highly recommend that all cases are reviewed for appropriateness of ACLS by 2 or more qualified physicians, and they can be your CT surgeon, your advanced heart failure, or your cardiothoracic ICU intensivist. That helps out. And again, if not met by criteria, the patient's excluded, then 2 of the physicians listed above must come to an agreement that they're not medically appropriate before declining the case. And that's just pretty much our practice at our facility. Documentation, another thing that's I find very important is knowing their past medical history, having access to their electronic health record. That can give you a lot of information. Documentation and referring to the sequence of events, what came first. And then should the patient be declined, the rationale for declining is to decline and all that. So some of our references. And then open to any questions. So I got a question here talking about experience with plasmapheresis and heparin. So it was a patient who was positive hit, heparin allergy. Their exit strategy when discussed was going to be to transplant. Well, patient with a virgin chest, no other prior cardiac surgical histories, biventricular failure. Really, the only best suitable exit strategy was going to be the transplant. So, patient was placed on plasmapheresis through our ECMO circuit a couple of days prior to surgery, or a couple of days prior to surgery, and then once to eliminate some of those antibodies. And then once a patient received an offer immediately before, they were able to receive heparin during the surgery and then immediately following, and patient was transplanted and did well, actually discharged home. But plasmapheresis came into play, and that was the first case for myself too as well. But patient did really, really well. Please feel free to scan the QR code, email me a question, reach out, it's fine. Anything you'd like to float, I'm open to helping out anyone who's looking forward. And thank you again for inviting me to the conference here. Mohammed and Sherry, I know you did a lot of work behind the scenes, and this has turned out to be a great experience for myself as well.